understand is tropic hormones that affect the heart. Now, tropic hormones specifically refer to hormones that affect the organs they're near, right? And so if this trash can released a tropic hormone, what we shouldn't suspect necessarily is that it's affecting the window over here. It's just simply too far away. It's largely affecting the area that it surrounds. Now, where we get these, now admittedly, these are tropic hormones, and these are the effects of those, the varying tropic effects of those things. But what this means is I have a brain, believe it or not, and it has a wire, okay, that goes down to my heart. In fact, it has 2 wires, though it likely has more. One of those is a vagus nerve. What does the vagus nerve do? Excuse me.
Blood pressure, right?
Kinda.
Doesn't it? It's your blood pressure, right?
Kinda. It does what? If you think about, I have a I'm really kind of reducing this, partly because I don't know much more than this, but if we have a sympathetic nerve and a parasympathetic nerve going to our heart. And the parasympathetic nerve is the vagus nerve. Now, if I squeeze your sympathetic nerve, like an orange, and squeeze it, and orange juice comes out, what do you suppose comes out when I squeeze your sympathetic nerve? What is that? If I squeeze hard enough, maybe? But a hormone comes out. Are you surprised to learn that it's adrenaline, that it's epi? And norepi. The point is that we do release epi and norepi from our adrenal glands. That much is true. But we also release it straight from the wire. What that means is we don't have to wait for a metabolic or hormonal shift to occur. I can see something, my heart goes up instantly because the wire goes directly into the heart, and the wire itself can release tropic hormones to immediately impact it. Or put very simply, I see a bear, a wire sends a signal directly to my heart that's just like, hey, remember that small bucket of epi you got? Just pour it right in. Basically. But what we need to know on top of that is we have to know, okay, so epi goes into the heart, right? And epi only causes bronchial dilation. No, it does all kinds of things. In fact, it affects alpha receptors causing vasoconstriction. It affects beta-2 receptors causing bronchodilation, but it also affects beta-1 receptors in 3 ways. Okay? If I were, and how I remember this would be a chronotropic, this is a chronograph, right? It's a fancy way of saying that. Chrono is time, that's the rate. So if I gave you a medication, Tony, if I just bolused you with 10 cc's of a chronotropic medication, caused a positive effect, what would you expect would happen to your heart rate?
It would increase.
It would increase. If I'm giving you increased chronotropic effect, I'm going to increase your heart rate. And so the inverse of that is also true. If I decrease your chronotropic rate or chronotropic effects, or more to the point, if your heart is suffering chronotropic effects, its rate is going to be lower. That's not the end of the equation, is it? What is the equation for cardiac output? It's not just chronotropic effects. It's not all of it, right? What's another part of it? Heart rate times stroke volume, right? And that stroke volume is essentially in part regulated by your inotropic effects. I remember this as pumping iron. That's the muscle contraction. What that means is even if you have the appropriate rate, you have good chronotropic effects occurring, and your rate is 80, great job. But your inotropic effects, your muscle contraction is low, your stroke volume is going to suffer. Even though you have the right amount of fluid, you just can't squeeze it hard enough, so I need to make sure that I give you a medication that now increases the inotropic effects of that. Dromotropic is the third part of that, and that goes back to our cardiac cell discussion about excitation, conductivity, and automaticity. This is the electronic part of that. I remember dromotropic like a drone, an electronic drone. What that means is that even if your heart, your SA node is okay, and it's exchanging chemicals in a sense that causes your sinus rate to be just fine, okay? And even if your heart is squeezing at the strength that it needs to, not too much, not too little, the inotropic effects are normal. If it can't cause the message to be replete through your system, if it can't have appropriate automaticity, or rather conductivity or excitation, then you're going to have a major issue. So all three of these things are necessary, and that's part of the reason why we have things like epi and norepi, because they affect different portions of this. Not that you need to remember this, but norepi specifically is going to cause a major increase in chronotropic and dromotropic effects, but not so much inotropic effects. And you say, wait, aren't all three a good thing? Well, they are in moderation, right? Everything is a poison. If essentially I don't need more squeezing done and I give a medication that causes that, it might put me up a creek. So more than anything, you need to know that these tropic hormones that are released will either be agonizing in these effects or antagonizing these effects, and that the positive issuing, the agonist of this, is going to cause them to go up or increase, and the inverse is also true. Excuse me 1 second.
Before you go on, can I ask, the dromotropic electrical that we're increasing or decreasing the electrical impulse? What was it? I missed.
It is best to kind of view it as, tell me if this is helpful in any way. The shortest answer is yes. Shortest answer is yes. This is your heart rate. This is how hard it squeezes. This is the electrical part.
So if I have an increased electrical impulse, what is that an increased electrical impulse do? Right, like, so rate,
You would very rarely get an isolated increased electrical sensitivity, essentially. But what we can say for sure is that if for some reason you're having like a electrolyte shift, put very simply, we generate electricity by moving electrolytes across a cell wall. And if your dromotropic effects are impacted negatively, maybe you have too much potassium or not enough, or whatever the case is, and so now you're not appropriately conducting electricity, you have a problem in these dromotropic effects.
Okay.
And you'd say, well, yeah, but I have a fine heart rate. So heart rate is a little different. That's mostly governing automaticity, not how much these messages travel to the next cell.
Acabo listo en las 15 minutos. 15. Niego. De nada, adiós.
If you don't want to wait on this. This is an important distinction. Not, to be honest, not necessarily this. Atherosclerosis, it's most important that you know atherosclerosis is a hardening secondary to plaque. Oops, that's me again. But we could also have stenosis of the arteries, and that would also cause an issue as well. It doesn't necessarily have to be a buildup on the inside. It could also be an issue where we have a hardening of those vessels, and therefore it's just not expanding in the way that we need it. But either way, it's causing an issue from hypoperfusion. Right? And in part, this, if you had to look at this, what would we suspect? Arteriosclerosis or atherosclerosis? Atheros got the Plizac in it, right? It's important to remember, the best way I get through this as far as, you could potentially see questions about thrombus or embolus. I just remember that its Christian name is thromboembolism, right? And that's how I remember the order. If I can remember that it's thromboembolism, I remember that it starts as a thrombus, and when a chunk breaks off of it, if I said that wrong, it starts as a thrombus and then becomes an embolus, right? That's important to know. And that it only ever, like, our body has emboluses from time to time. And mostly it's a non-issue because in a healthy situation, your body will break that down given enough time. It can happen. But it becomes an issue when our body is unable to break it down, or the plaque that can't be broken down in general suddenly reaches a smaller vessel and therefore starts to literally occlude it. Somebody give me an example of what this might present as in pathology. What kind of conditions is this? Sure, there's one. I like it. What else? Stroke. Very good. What else you got? DVT and a heart attack, right? Is this angina? That's a good reaction. No is correct. Right? This could be, up here, thrombus. But when we suspect occlusion, we should be thinking more infarct issues, less that it's ischemic. Ray, do you remember the difference between ischemia and infarct? It doesn't have to be fancy.
Death of tissue and not.
I slug you in the arm, it hurts, but your muscle doesn't die. It just hurts because I've disrupted the tissue. I've caused a sudden lack of perfusion. Your body heals from it, that was ischemia, and it's no big deal. I punch you so hard that it completely disrupts the blood flow, that tissue dies now, right? And that would be what we call infarct. And you will definitely get asked questions that have you differentiating. Do you suspect this to be a heart attack? Do you suspect this to be ischemic? Do you suspect this to be angina and that? And so you'll need to kind of find ways to differentiate why you might suspect it's one or the other. If I were to kind of toss you a softball and say, what's one way that how would I get you to decide whether this patient is suffering from an acute myocardial infarction, an AMI, or a tension pneumo? How would you make those distinctions? Vitals and story, can you give me any examples?
Between a heart attack and a pneumonia.
Sure. I read a question at the end, I'm like, this is clearly heart attack, this is clearly tension pneumo. What's a story element that might...
I woke up, my chest started hurting before, for regards to, I got hit by a car.
Sure, right, yeah, and those are good examples, dramatic examples. It can be difficult. Hear me when I say that oh no, do I have to be careful with this? I don't know if I have to be careful with this yet, but here's something that I'll tell you. It can be incredibly difficult to differentiate some of these things. As a clinician, I err on the side of catastrophe. Guy says, I have chest tightness. All vitals are fine. What should you suspect? Heart attack. If that's all the question said, guy has chest pain, what should you suspect? I'm like, well, heart attack, I guess. You didn't mention trauma. You would need a mention of trauma before I suspected a traumatic event at all. Is that true? I don't even know if that's true. So as the story adds on to it, he says, he was just sitting there, then he had pain. I'm like, honestly, I don't know how to differentiate that from a specific type of angina and a heart attack. There's not enough info there. I don't really know. But if you ask me the question of, my guy's just sitting there, and then do you think it's tension pneumo or stable angina, that might be a different story. Or differentiating stable versus unstable, and we'll kind of get into that as well. But rest assured that it's not enough to just know anymore what these things are. You have to also know how to differentiate them. So your flashcards, if you're making them, shouldn't necessarily just say, what is stable angina? It should be a question. How would you know that it's stable angina versus unstable? Not just, what is it? When we talk about angina, hopefully as a reminder, we talk about stable angina because, much like in your homework packet begs you to say, The stable angina comes with a story. It makes sense, right? It may not be good, but it makes sense. You've got a history of heart disease. You tried to lift a bunch of stuff today. Now your heart hurts, man. No mystery there. That's a stable solution. Unstable is I'm cruising along at 36. Suddenly I'm short of breath. I'm getting pale, and my chest hurts like the dickens. Well, what happened, dude? I have no idea. Okay, that is not a stable solution. Something came out of nowhere to cause chest pain, and that is unstable angina. It makes no sense. It has no story, and that's really my descriptor. It's stable angina often comes with a story. It makes sense. It's not good. It makes sense. And this is often mostly associated with both stress and effort, and we should assume then that it's often relieved by stress and effort. Now be careful here. If I'm asking you to differentiate between stable and unstable, this makes total sense. I gave the dude nitro, it went away. Do you think it's stable angina or unstable? Stable, makes sense, right? It's got a story, it has a solution, da-da-da. But now if I asked you, your patient was given nitro and he feels better, is it stable angina or unstable angina or a heart attack? There isn't an answer to that question. How could you know? What is the value? India, what's the value of giving a patient nitro that's having a heart attack? What's the value?
Reduces preload.
Reduces preload? Okay. What else? Preload is just the winning answer.
It's a dilator. It's going to open your vessels more.
It's just the blood theoretically can flow around the occlusion, right? Yeah, all good answers. All good answers. So, in theory, if we're looking at, let's take for example, a situation where we have unstable angina, which often is the result of a thrombus, or could be some type of stenosis issue, and we cause vasodilation, we would expect that person to have relief, would we not? No, that's not fair for unstable angina. Let me start over. You can differentiate stable and unstable angina because rest is helping, okay? Because medication is helping. But medication and rest can also help a full occlusion, which is why you can't just say, well, I gave him nitro and now he's feeling better. That's stable angina for sure. He said, no, it could be a heart attack and it could be working. It's possible, right? So we should be careful with that. The big difference here between the sneaky one, I don't know how they're going to ask you whether they say variant or Prinzmetal angina, is that it has nothing to do with internal occlusion at all. Or at least, maybe that's a bit of a misnomer. That's not the origin of your problem. The origin is on the outside. Can someone give me a respiratory example of these two concepts, a respiratory version of these two things? Amanda. Zoom out. These are no longer vessels. That's no longer a thrombus. But conceptually, I've got an airway problem that is originating from the inside and one that's originating from the outside. What does that sound like? Say it again. Bronchospasm is an inside or outside issue?
Inside. No,
Oops.
outside.
Right. It's the spasming of the vessel collapsing. Great. What might be an inside problem that's a little like unstable angina? Right? Grab your, so you see your water there, right? Unscrew the cap. Keep going. Keep going. Great. Good job. Pop in your mouth. What's up? Pop in your mouth. You're learning here. Get ready to educate.
The water?
No.
What?
Pop the lid in your mouth. Ready to learn something you never forget? Okay, now choke to death. So what am I trying to say, right? Bronchoconstriction is an outside problem. What might be an inside problem?
I'm just confused. Sorry.
Sure.
Like an occlusion or?
Occlusion. I'm choking on something.
Okay.
I tried to teach you, but you refused to learn. Education's happening here, whether it means you're deaf or not.
Good thing everyone was
Really
up to
don't care about
that.
graduation.
If you walk into a cardiology test, you walk into the final, you walk into registry, and you cannot differentiate explicitly these three angina, you are wasting your time there. Okay, this is important stuff to know. It's also worth knowing, and here's part of the distinguishing things. In fact, I find the time and I'll do it for you, right? I think you should make flashcards. I almost made those for you on the heart, so you can say, hey, that's VFib, that's VTAC, whatever. Okay? If I do that for you, you lose. What do I always say? Study guides are mostly beneficial for the people that make them, because of what you learn as you're trying to kind of consolidate this stuff, right? I don't understand. India made a bunch of flashcards and Lucy used it, but Lucy struggled and India did fine. Or Trinity made a bunch of, Trinity used Lucy's flashcards that was given by India, and then Trinity, I'm like, okay, because it's the making of them that really is the benefit. Just utilizing them can be problematic, right? What kind of vital signs, if I've got a guy, how do I want to phrase this? Could I do that? I don't know that we can go down that path. Anyways, we want to be able to differentiate these things both in concept and otherwise. Oh, here's what I mean to say. I got you right. If you've got a patient that has a blood pressure of 70/40 and has an irregular heart rate, what should you suspect? Stable angina, unstable angina, Prinz metal angina, or a myocardial infarction? Were you raising your hands? You got to pop out?
No,
Oh.
I had a question, but sorry.
You good? Also.
Question?
You have a patient whose blood pressure is 70/40 and is experiencing an irregular heartbeat. What should you suspect? Stable angina, unstable angina, Prinz metal angina, myocardial infarction. Okay.
Crickets.
The summary of this question is, do you die from angina? Unlikely.
I was about to say, wouldn't it be a myocardial infarction because the blood pressures?
Say again?
Wouldn't it be a myocardial infarction because of the blood pressure because it's 70/40?
What separates? I don't know if you can die from angina, but if I had to say which of those is more deadly, it's infarction by 1,000%. Why am I saying that, right? Because how does this image differ from a myocardial infarction?
With the myocardial infarction, part of the heart tissue is dying before you're,
How is it dying
How
if
is
it's
it
got blood
affected?
flowing to it?
it's occluded.
Because this is a partial occlusion, and an infarction is a total occlusion. Total eclipse of the heart. Yeah.
Good stuff.
Okay, so do you see how I kind of structured that? Before it was very confusing. I don't know which one of these. Okay, but think of is a person with a 70/40 blood pressure and an irregular heart rate, are they in cardiogenic shock? Yeah, and we can guess that because not only do they have, if I just said your guy's got hypotension, what type of shock is it? You should respond, what? 1 million? What are you talking about? But suddenly I say his heart is in a dysrhythmia, you should be like, oh, well then maybe that's the problem. His heart is beating so irregularly that it's causing this. Right? And so that'll be what you have to do. Why is it, man, occlusion, not occlusion, you can die from too little oxygenation, it can cause all these things. Yeah, but if you had to pick, which of these is clear, if you said, hey, I got all these 3 anginas plus a heart attack and you get to pick one, which one do you not pick? Myocardial infarction. Why? Because it's a full occlusion of the vessel. Infarction denotes that we've gone past ischemia and gone into death. And that's why a lot of these are referred to as demand or supply ischemia, because they're not killing the tissue, it's just not enough. Okay. I'm not sure that a more important conversation has occurred for us in this class than that one we just had. Great. Good. This is what it looks like. Yeah, here we are. Be a little careful of this. Ludwig's angina, this is not cardiovascular in nature. This is an infection underneath the submandibular. I don't need you to know that, but what I'm saying is if you see this on the registry, it's probably the wrong answer. This is what those people look like. It kind of looks like goiters or like he's got a second tongue. Angina is it's not a nonsense word, what is it? It's a generic word. It means a tightening. Ray, do you remember your question?
I'm sorry, say that again?
Do you remember your question? I think this was the image, maybe not.
The vasospasm,
Yeah.
is that specific to like the heart?
It's largely idiopathic is my understanding. Oh, and yes, it is the heart. Oh, that's interesting.
Like
Yeah.
coronary vessels of,
It should be suspected that all of these are coronary vessels.
Okay.
Yes.
And
Yeah, a guy that has angina is not experiencing a narrowing specifically because he's got a narrowing in his arm.
right.
That's a very good question. Hence why we have chest tightness, not specifically like finger or feet or whatever. Yeah, good question. But vasospasmodic is largely idiopathic in my understanding.
Like, are you gonna know vasospasm?
As a clinician, no, you absolutely will not.
Okay.
You're gonna walk up to a guy and he's gonna say, my chest hurts. His vital signs may be perfect in every way. And you should think, you should go to the hospital, dude, because this could be a heart attack, this could be angina, this could be a lung disease, this could be, dude, just chest pain. It could be something that kills you or no big deal. And it's not really until we start getting story or differing signs and symptoms that we can even start parsing this out, right? Guy says, I had a heart attack last week. Do you think this one's angina? No, I don't. You just said you had a heart attack last year. Something in your body is making clots and not getting rid of them. It's probably another heart attack, dude. You don't know that. You don't know that. No, I don't know that. But a smart dude would suspect a heart attack over angina at this point. He had no history of angina. He did have a history of heart attacks. It's probably a heart attack now. No, as a clinician, you won't know. But we should suspect the worst and encourage people that, hey, I know you have a history of angina. Do you know, by the way, what the treatment, the home treatment is for angina? Nitro. Do we know how much?
Like warm over, sublingual.
Yeah, it's the same as yours. What they tell people is, hey, you will live for the rest of your life. Ideally in an angina condition that never gets worse. Ideally. You will have sudden impacts of chest pain. You are to take 3 nitro and then call an ambulance if those 3 nitro didn't help. Because it might be a heart attack now. What should you suspect about people with angina? Why are people with angina more likely to suffer myocardial infarction?
Because you're more likely to like assume that it's just angina and then maybe.
Maybe. I don't know that, but maybe.
Impairs the abilities of the heart.
It does. Why is that? Why, if you have angina, are you more likely to have a heart attack than me without angina?
Depends on the type of it, but thrombus is limiting blood flow. Vasospasm is limiting blood flow.
Nice. One free high five from Peyton. You may cash it in now. Okay, so the point is, look at this, right? If my vessel is wide open and I get a embolus rolling through it, maybe not the biggest of deals. But if some of my coronary vessels are already suffering from thrombuses that already exist there, I'm now way more likely, because look how narrow that vessel is. So a real tricky question that I could ask is something like, let me ask you guys this. I don't know that we even really know this. We've been saying heart attack, and we know that the end of the line from a heart attack so bad is what state? Death. It's death. We get that. But there's a ton of crap that happens in between, right? And we know that because we talked about Amanda having a sudden issue. She pales out. She goes unresponsive. A lot of stuff happens before death, right? Sometimes pallor, sometimes diaphoresis, sometimes jaw pain, shoulder pain, elbow pain, sometimes whatever. Number 1 sign of a heart attack in women is?
Back pain.
Say it again.
Back pain.
Nope. Weakness. Chick walks up or sitting in their living room and says, I don't know, I just feel weak all of a sudden. 12 leave. 12 leave. For sure.
My sister's mom, her heart attack was a tummy ache for 2 days.
Yeah, sure.
2 days of stomach
Chicks
ache,
are weird,
and
right?
it was a horrible heart attack. She was like, they were like, I can't even believe you're walking.
Yeah, I don't know what the difference is. And more to the point than knowing that that's the number 1 cause of women, that's not a test question. You should just know that people can die from heart attacks, don't feel like you think they should, right? Guy's just like, I don't know, man. Just got these weird black spots. I don't even wear glasses. Why do I have these black spots in my vision?
I feel like everyone in here is on paramedic TikTok now. My favorite one so far was this guy. He was sitting in his patient. He goes, "Oh, it feels stomach's kind of hurting now." He goes, "Oh, yeah, we'll just try to." He goes, "Tearing." He's like,
Yeah, I've
I
seen
saw
that and I was like,
Yeah, not a whole lot
you said
causes
what?
to-
He said,
Why would it?
It's like, hmm?
Why would it? How is it even possible that a patient might have visual deficit because of a myocardial infarction? Say it again. That's right. It's hypoxic, right? Hypoxemia, maybe? Right, very good. Very good. Oh, that's where we're going. That's why I want to talk about that stuff. About the route we get to, okay? Or what it actually looks like. Can anybody tell me what you guys know about this? What is it?
Discharges in the heart.
I love that. Electrical discharge. How would you be able to discern if it were mechanical? If this had a pulse, it would have a pulse. Whoops. Great.
I was
Genius.
like, yep. I was like, yep.
Is this fast or slow? Uh-oh.
I mean, seems kind of normal. Maybe. I don't know.
What do you know about?
I can't interpret.
Anyway, this is tricky for a number of different reasons, not the least of which is very difficult. This is likely a 3-second mark here, but I don't necessarily know that. It very likely is a 3-second mark, so that times 20. But we can count by the boxes. Even the boxes are hard to read. So what I want to kind of get into a conversation of is really kind of what we're looking at here, but be careful. What I would rather you do is be able to be like bradycardia. Not tachy, not right, not asystole, not VTach, not VFib. That's either a normal rhythm that's the right speed, too fast or too slow, and it's probably not too fast because there's not a million of them. Like, I'd rather the overarching concepts be true for you, okay? Now what happens to this, let's say that this person suddenly develops a heart attack. Now I didn't take a 12 lead, right? And that's really what 12 leads are doing. Monitors, putting a person on a monitor, the 3 leads, right? That's mostly just to discern dysrhythmias, because I can't look for occlusions until I do a 12 lead, or at least I should say, you shouldn't. The number of times a dude has said, I think this is a heart attack, and slides me a 3 lead, I'm like, Jesus Christ, what are you talking about? For 2 reasons. Number 1, the 3 lead is like a magnifying glass at the heart, and a 12 lead is a microscope. And what this is doing is it is interpreting the data. What you see here isn't always exactly what's happening. It's much like hearing a dog barking out in the hall and I ask you what color it is. And you're like, I mean, based on the evidence and the fact that I saw it's interpreting things. In fact, I put on 12 leads, right? And so we see how many representations. Not really a trick here. 12, right? 12 leads. 12 things shows 12 images, okay? 1 image with 12 parts. If I put you on a 3 lead, how many images am I seeing? 3, right? Because the lead, if you remember, right? We've got lead 1, lead 2, and then lead 3. I shouldn't point to it, but lead 3. We have 3 views of the heart, therefore it will represent 3 times. If I put you on the monitor with all 4 electrodes and hit print, I mean in most cases it'll print 1, but it can see all 3. That's the point of the ground, is to allow you to see all 3 at the same time. So if I put someone on a 3 lead, well, this is a lead. This is a visual representation of a lead. Therefore a 3 lead has 3 images. Okay? Here's what's interesting. If I were to take somebody and put 4 electrodes on them, I'm now doing a 3 lead, right? Because 1's the neutral. But if I force the machine to interpret a 12 lead off of those 3 leads, how many images are displayed? Any guesses? This is more of even a logic puzzle than anything. The right answer is the wrong answer here, but you might expect, well, if I want to do a 12 lead, I have to put stickers on the chest, so only 3 would show. If I put a 12 lead on, right? I mean, if I don't put those stickers on, then I don't get those leads, so therefore only 3 would show. That's the correct wrong answer. That's the right logical answer. And this is why AI programming is difficult, because this requires lateral thinking, not if-then binary thinking. Have you ever heard these terms? You've heard of leads 1, 2, 3, yes? Mm-hmm. You've heard of V1 through V6, yeah? Yeah. What are the ones I'm not saying? A, VR, AVL, AVF. That A stands for augmented. What that means is interpreted. It's not real. It's theorized because math works out. What that means is I can calculate the length of a telephone pole because I see the shadow, or the distance between those rather, right? The augmented leads, in fact, if I put somebody on 4 stickers and say, just do a 12 lead, it'll say, you haven't put up on the stickers. I say, that's okay, do it anyway. It will print 6 leads. Because the augmented leads are interpreting, okay, if the lead 1 is going this way and lead 2 is going this way, then it must mathematically mean that if I look at it this way, it presents as such. That's how if you know 2 sides of a triangle, you know the third, right? You ready to learn Pythagorean's theorem? Okay. So the point is here is that a lot of the monitor, right? Isn't that Pythagorean's?
Yeah.
Okay. Hypotenuse of a right triangle? I don't remember what it is. A squared, B squared, C squared.
Yeah.
Is that plus?
A squared plus B squared equals C squared.
I did that yesterday on T-Steps.
somewhere my wife is very upset with me. All right, the point I'm trying to make is that the monitor is interpreting stuff. It's interpreting stuff. What you see isn't always what you're getting. And so many times people will show me a 3 lead and say, I see a heart attack. I hook up the leads and push print, and the heart attack's gone. Why? Because I gave it more power. I'm zooming in closer. Because sometimes it will say, hey, I think this is a heart attack based on the limited power you gave me. That's like me hearing a sound and saying, I think it was a man I heard. I open the door, I get closer. Nope, it wasn't. So when we give it more authority, more power, so in the 12 lead, we can start to really kind of see the infarct. That's the whole point of it. And it's why it's now imperative for you guys to do a 12 lead on almost every patient that you get in our lab and in your clinicals. Because even though you're not allowed to interpret it, it's still important to get and then send to the hospital. And I don't know that we're even going to get into the woods of how to do that. Changes on the monitor, changes on the company. You have to sync to the truck and Bluetooth a modem and blah, blah, blah. All I need from you is to say, I would transmit my 12 lead to the hospital. Great, point, good job. You forget to say, I'm going to send this to the hospital? No point, bad. And that might matter when it matters more. Guy breaks a toe and you forget to say it, I'll probably still give you a point for it. But what you should think now, and here's how I want our scenarios to change. Hopefully this is already occurring. I walk up, what's my general impression? Hey sir, can you hear me? Okay, hey, my name is Steven, what's your name? And how old are you? 81. Look, my partner here, Sue, is gonna get a full set of vitals while I assess you. Is that all right? Sounds good. Okay. Proctor, what's my ABCs? And so on and so forth, because we have to. In EMT, I was like, don't do that, don't interrupt the time, make sure that they have a pulse before you da-da-da. We have too much stuff now to wait for that. So have your partner, ghost or not, say, full set of vitals, blood pressure, cuff, but you might have to articulate it, right? I might coach your partner and say, hey, when she asks for full set of vitals, only put them on the blood pressure cuff, right? So make sure, like I would say, hey, we're gonna do a full set of vitals here, Sue. That means blood pressure monitor, go ahead and put them on end tidal, whatever the case is, okay? In addition to that, at some point, we'll need to say, okay, I'm gonna go ahead and now attach a 12 lead, whether we can verbalize that or not. Your brain should not think, I'm not a medic, I shouldn't do a 12 lead. No, wrong. You should be doing 12 leads. Does anybody get in trouble? Not many people get in trouble for doing a 12 lead when they shouldn't. What is a situation that you might get in trouble or be wrong for doing a 12 lead when you shouldn't?
Never there's an immediate left or right.
There you go. If you're doing a 12 lead and this guy needs oxygen and you're sending the time to pull up a shirt, shave his chest, attach the stick, okay, no. Right?
I hate shaving your chest. It's such a pain. It's a
Sure.
process.
I don't. That's why it's like
sticker.
a jungle.
I've had to on a clinical.
Yeah.
It was such a pain.
What do you do for AED when you gotta shave and you don't have one?
Rip off.
Right? Use one pads, grab the other.
That just runs the portable version.
Yeah, it's just like that. Okay, so you guys need to be thinking 12 leads. 12 leads, and that's the true for everything. End title, transmitting, drawing labs, all these AEMT skills, in fact, any skills, EMT or medic, if you're interrupting life-saving interventions to do them, you're doing them at the wrong time. Right? In addition to that, the 12 lead, it's better to just do them basically all the time, but some very obvious scenarios are like focused trauma experiences. Dude's cutting a branch, he falls on the ground, he's bleeding from the chest or whatever. You still have to do all those direct pressure things, but maybe we don't necessarily prioritize a 12 lead in this isolated trauma experience, but it doesn't mean we don't do one. Why would my guy who has a limb sticking out of his chest while he was cut, his wife said, I watched him up there, he fell out of the tree, that he landed on the limb, he's got a punctured lung, you treated according with an occlusive dressing, suspecting tension pneumo, why might you still do a 12 lead?
He might be having a heart attack.
Why might he, he might have had a heart attack and that's why he fell, right? So what I'm not saying to you is just like, you really need to know when to do these and not do these. No, you should probably always do them. But sometimes it's the last thing you do. Sometimes it's the first thing. And there's no easy answer for that other than, the more confusing the call is, the sooner you should do a 12 lead, basically. Woman says, she's in cuffs. She says, I walked up, I shot my husband right in the chest. Okay, I'm not saying don't do a 12 lead, but you will probably run out of time before you do one because there's no suspicion this guy was dying of a heart attack right before his wife shot him. That's low priority. Anything else you'd like to do before you finish this scenario? Yeah, I guess I'd do a 12 lead as well. Great. See what I'm saying? If you remember, when I used to teach the medics cardiology, I would say, look, I can list all the reasons why you should do a 12 lead: chest pain, difficulty breathing, but it's better to do one all the damn time, right? Just make sure you're not interrupting life-saving things. Okay, so this guy has a heart attack right now. Now, this isn't what a heart attack looks like, but let's say he got one after this. What happens to his heart? It occludes, it starts to get ischemic, maybe it dies and infarcts. His rhythm might change, yeah? Much like if I've got this little girl here, I'm spinning my kid, and I spin her too fast, she goes off the rails, right? Your heart can do the same thing. If I walk up and India's unresponsive, and I palpate India's pulse, presuming it's not a sock, right? And it's irregular, I might now think she is unresponsive because of that irregular heart. Why would an irregular heart make someone unresponsive?
No blood flow to the brain.
No flow or not enough? Why would irregularity? I didn't say slow. I didn't say too fast. Why would irregular mean that? Inconsistent, sure, and often does mean slow, because if it's irregular, I have too far of spans before that happens. Could a heart rate that is beating too fast lead to your death? So in a sense, tachycardia could be a lethal dysrhythmia, yeah? Right? Destiny, why would a heart rate that's beating at 300 beats a minute, why could a person die from that?
Because you're not getting the amount of blood around
That's
that
right.
you should.
Preload
and
too
your heart's
low, right?
Working too
It's
much.
not pre-filling? Very good. And the same thing is true and a little more obvious for bradycardia, which means I need you to know when something's tachy and brady. I don't need you to be able to count or specifically differentiate the depth of these things, not necessarily, but I need you to for me to look at that and say, I don't know, it's either normal or slow, but it's not fast, right? And in fact, if we looked at a much harsher rhythm, what is this one? V-fib. Now, I know that in an isolated situation, it's hard to discern whether or not that's bradycardia. Don't start with that one. But I need you to say, that one is V-fib, that one is not V-fib. That's what I need from you. What I don't need is for you to be able to differentiate these things on a very, very deep level. Now, if I put this up here, and I said one of these is tachy, one of these is brady, you should be able to do that, yeah?
Mhm.
And part of that, what you're doing instinctively, is you're like, okay, well, there's just more of them here than there. But what you're specifically identifying is the triangles. There are more triangles here. And that triangle is what? It's the what wave? It's a QRS complex, and specifically the ventricular depolarization, right? Could you live if you had all triangles and no bumps? Could you live? What I'm saying is, what am I saying? Can you say what I'm saying in another way? If you had all triangles, no bumps, you now have all.
Chemical or all mechanical?
Well, you would be missing some of your chemical. What do you got?
Your atrial would be depolarized.
You'd have atrial standstill and ventricular depolarization. So the question is could you live with only ventricular activity?
No.
You can.
Oh, well, you can have AFib and be alive, so I guess.
AFib and be alive
But how do your ventricles get filled?
very sparingly.
So, like, over
So-
a
What
short
does that
lifetime,
look
you can live?
What does that look
Well,
like?
you know what it looks like already. You know how I can prove it?
Pulse.
Because you have to check for a pulse before you put an AED on, because sometimes VTAC, which is only ventricular depolarization, has a pulse. Not forever.
Doesn't last.
It doesn't last. I've seen it last for hours, but
That's crazy.
I thought so too. Well, I have heard it lasts for hours. I have personally seen it last for like 40 minutes. I killed a guy.
Oops.
He was in VTAC. His blood pressure was dropping lower and lower and lower and lower. So I cardioverted him. I said, hey buddy, I'm gonna shock you here. I'm gonna reset your heart. Goes from a heart rate that's 150 ventricular rhythm to a heart rate that's 250 ventricular rhythm. And here's a lesson for you. I'll say this. Every time you see a rhythm change, you do a pulse check. Ooh, do I want to tell you that? I don't know that I can tell you that if I'm not telling you, I can't tell you that. But that is what it is. You're not expected to interpret rhythms, okay? But you need to identify them. Anyway. His heart rate goes from 150 to 250. I check a pulse, no pulse. He's still in VTAC, but I killed him.
When something changes, just go back to your ABC.
I was like, oh! So I immediately defibrillate him. Why did I immediately defibrillate him and not initiate CPR? No pulse, CPR, right? Go get the AED. When do we apply the AED? As soon as it arrives. It was right next to me, so I put it on. So a good answer here is we apply the AED as soon as it arrives. Well, it was right next to me, so I did that. But what's the physiological answer?
Because he's 30 and 100 people come back from VTAC and you let him go to asystole, which could have an instant home.
It could.
Yeah.
Right? Everyone close your mouths. Hold your breath. 1, 2, 3. Why aren't you dead? You stopped breathing. Why didn't you die? You can breathe now.
Because you still have reserve left.
You still have circulating oxygen, don't you? He stopped breathing, and I didn't do CPR. Why? Because he still had enough oxygen already in his tissues. What he didn't need is for me to do crappy circulation with CPR, which is what all CPR is. It's better than none, but it's still crap. So I shocked him, came back to life. I was like, hey, good news, bad news. First of all, you're welcome, okay, for saving your life. Also, my bad for killing you.
Oops.
Okay? What you need to know is that the end point of a heart attack is death, but the road to get there can present. Could this be the result of a heart attack? Hell yes, it could. This is what it looks like when the heart isn't getting what it needs or when it's acting out of turn. Do you remember when I talked about the tropic hormones, or rather, that's not what I mean to talk about cardiac cells and excitation? This is too excited. This is lack of organization. This is too excited. How would it get there? Well, like a petulant kid, if you don't give a heart enough oxygen, they get real cranky. Right? Like when I'm choking my children. No oxygen makes them cranky. It makes me cranky when I stop breathing. It makes the heart even crankier. You see this rhythm, and all of a sudden one is out of turn, one looks upside down, one looks weird. You should be thinking, this guy needs fluid or oxygen or sugar. Yeah? And then on a long enough timeline that it dies. Take a quick break. It's 11. Let's call it 11:06.
Yeah, I got drinky jokes. I don't make the rules.
Do you know a whole lot about like inappropriate sinus tachycardia?
Inappropriate sinus tachycardia.
Yeah.
I guess I wouldn't describe it as knowing a lot. I know some. I would say that what you just described to me is tachycardia. Sinus tachycardia means it's coming from its sinus node, which is good. And if I asked you what's the #1 cause of tachycardia, you'd say, yep, which is tachycardia. It's represented often by thirst, and all these kind of things. So I'd say most cases, tachycardia is just either too little fluid or too much stimulant. And in fact, I've had 4 or so people in my life where they're just like, dude, you're like medical, right? Like, I keep getting this like short of breath stuff. And I say, yeah, check your heart rate, it's probably too high. I say, how much coffee do you drink? I say, not much, but 1 every day. I said, stop drinking it for a week. And every single one of those guys, their heart never did that again, even though it's doing it every day. So in my limited experience or anecdotal, it's usually too little fluid or too much, but it can indicate all kinds of things. It can indicate valvular issues, that your heart is speeding up because of the proximity. So if you said, my heart rate is always high, no matter how much I drink, no matter how much I sleep, I've cut out caffeine and it's still high, I'm like, you should go see a doctor. They'll look at your, that's the exact situation my wife is in right now.
Yeah,
Where
because
she's having bouts of
that's what I've done, and they were like, oh, you have inappropriate sinus tachycardia. Nothing else is wrong with your heart, and it's because I have good old genetic condition that causes fun dysautonomia, like
Yeah.
clots and inappropriate sinus
I just
tachycardia.
recently developed horrible restless syndrome.
Ooh, that's not my poor wife.
Yeah.
At
I've
night
had it for a
she'll
couple
wake me up,
years,
she's
but
like,
just this recently it's gotten
Did you have
really
something
bad.
or just chilling?
So for nursing, there's like 4 recreation sessions, and they're all on Mondays and Thursdays.
Sure.
So, I think it's in the March clinic.
Okay. Gotcha. Keep me abreast of that or whatever. If you were like, I have to miss Tuesday and Thursday, I'm like, okay, that makes you fail the class.
Well, I'll be
Email
here.
me and Mr. Denner will immediately reverse it.
Yeah, I'll be here. It's just like from 10 to 11. So I'll
Okay.
kind of take the test because the test that day.
Got it.
And then probably just sent out for
Cool. And then we'll be a stinky nurse.
Yeah, I took my T6 with me.
How was it? That's good, right?
That's great.
Yeah.
96% down.
Whoa!
Yeah, I haven't heard anyone get above an 80.
Yep.
So.
That is insane.
Yeah, well done.
That's my girlfriend. Absolutely big brain skills.
No, I had to go see another freaking doctor
Oh,
to go get.
I was really nervous about getting
Neurology.
nursing because especially at our program, there's
Oh.
like 500 people applying and 50
Whew.
Yeah.
and I gotta be in my grade, not that good, an attitude.
Yeah.
So I was like, I'm gonna do that and then to go next year, but
The fact that you
cushioning.
dropped a
is
fat.
like-
Yeah, on the
Yeah,
T's.
they're
You're like,
just
yeah, maybe I'll be
It's
alright.
about
My class was like,
per
oh,
grades. You have to do 4.
I'm gonna be okay.
And I'm like,
Phew,
That
get
sounds
records.
great.
yeah, I'm like, imagine.
Yeah.
Not being an A6.
Thank you.
Oh dear.
I was talking to my dad.
I got a super peak. I'm sorry.
I was talking to my dad. He's like, retired firefighter.
What?
Retired.
Ah.
He's gonna go,
The urination is gonna happen regardless of where I am. Yeah.
Guys, we'll have a lot of fun. So retired. Firefighter. I was talking to him. He's like, are you gonna be able to like slow your voice down and like
that
change
makes
your
me seem like
take the way you talk to people? And I'm like, I think
for
just
something
I think they also cut off the water.
Dude, I've heard people call. I really want
I just
to
got
get
to
called
watch
to
it.
pussy on stage so big. I don't know.
Just imagining someone saying that, just straight up in medical setting. I don't know why that. Oh man, should we need more water? Yes, I do. Dang it.
I just passed my room. This one.
Did you hear them? They start. They either start at 500 or 200 or anywhere in between 8 to 4 week. They're on our day will be Monday through Friday, 16.
What's the order?
Monday through Friday.
What is it?
So we have to walk on shipping coverage, looking at those beds and R&R.
Ray and we're in a group together today.
You're gonna like slow your voice down, like talk better ways. And I was like, dude, I've heard medics call people some crazy things. I'm not really worried about that.
Those are good for me. On my worst days, I'm still.
You're fine.
All right. So here we are with VFib on the right and VTAC on the left. Yeah? At least at this stage, are these two things obvious to you? I give you a test and I say which one is VTAC. Is this obvious to you? Here's what I'm sure of, gang. You have to know which of these 5 rhythms is which. You have to know that. But you don't need to talk about it much. I need you to be able to understand these things superficially, visually, but more in depth conceptually. What I mean by that is I need you to know, how would I look across the room, my patient has one of these 2 conditions, what might occur that makes me more suspicious of this one than this one?
The first one's a distinct pattern, the second one is more random.
Okay, I realize now I asked perhaps a misleading question, because even though that was accurate, I don't have the monitor. I just see John in the corner, he passes out. What thing might be occurring where I say, I don't think that's VTAC, I think we might be looking at VFib right now, without even looking at it? You wanna try? Definitely wouldn't have a pulse in this one, whereas this one could, that's fair. In fact, if I went over there and felt the pulse, I'm no longer thinking VFib, so good point.
They're not seizing.
Whatever the right answer would be, but mostly I mean presentation, I think.
Seizing.
Seizing. Your patient goes unresponsive, shakes for 5 seconds, what should you suspect? Asystole, you're like, what the hell, how would I know? Because only one of those traditionally presents with seizure-like activity. VFib will often do that. Now, I think we know by now that even vagal stimulation causes seizure-appearing activity. Do we know that? Right? Turns out when you hold your breath for too long, or your heart rate drops too low, or you pass out, hypoxia of the brain makes you shake a little bit.
I don't know. I haven't seen myself pass out before. That's my dad though.
Okay.
That was a fun experience.
I don't talk to your dad a whole lot, but your mom, I'll ask her. If I walk up and guy's like, I don't feel so good, and he passes out and shakes a little bit, I'm now thinking, okay, this might be VFib, it could be a vagal response, it could be an actual seizure. I need to check a pulse, right? Unresponsive, check a pulse. I check a pulse and I feel one. It's no longer VFib, but it could be any of the other ones, right? It could be. I put him up on a AED, doesn't say to shock, and so on and so forth. This is a different discussion. Okay. Right. So I need to be able to pull up a flashcard and you say definitely VTAC. To put a finer point on this, this is organized and largely symmetrical. Yeah. If these started to be earlier, a little later, but let's say that the shape didn't change at all, it just kind of moved around. Is that even helpful? I don't know. Here's the major point. You see how these are not all symmetrical, and some of them are falling at different times. This one's a mess. This one doesn't look awesome, but at least it's regular. It's falling regular. And it's largely symmetrical. Okay, so that one's a little different, but zoomed out enough, you can tell that's all the same heart pretty easily. Whereas if I chopped this and chopped that, you'd be like, those are completely different presentations, right? If you have to guess on which is which, the more disorganized of the two is surely VFib. Because this is VFib, right? I just signed you a sentence. Whereas this is asystole. You say, well, I thought asystole was inactivity of the heart, both mechanically and chemically. We would still... There's a longer discussion. There's a rhythm called PEA. Did we talk about that in the lab packet?
Yeah.
We drew it. The truth is every one of these basically could be PEA, pulseless electrical activity in a certain sense. You might look at that and I say, what rhythm is that? Or let's do this one. What rhythm is this? And you say, that's tachycardia. I say, how would you know that? You'd have to feel a pulse to know that that wasn't pulseless electrical activity. You'd have to feel a pulse. Otherwise, it could be. Anyway, I don't need you to know PEA, but gotta feel a pulse to know these things. I'm not sure if this is about to benefit or harm you. But here's what I say. If you get a strip like this and they say, what is this? Which I don't think they'll do. I think they'll show a picture of this and say, this is bradycardia or this is tachycardia. What should you do? That's what I think will happen. But if not, this is how we count it. Each one of these boxes are represented chronologically from left to right in time, meaning heartbeat 1, heartbeat 2, heartbeat 3, okay? And they are measured in amplitude, which is the amount of electricity. What would you expect if this heart were twice the size? What would you expect about the changes that might occur in this display?
The amplitude would be more.
Would be
Increased.
perfect.
Higher.
If this heart is twice the size, we would expect more amplitude. It would be bigger. Now, it doesn't always mean a bigger heart equals more electricity. It could mean more electricity equals more electricity. But the point is that the amount of electricity is measured in amplitude, which is raised by millimeters. One little box, 1 millimeter. 2 little boxes is 2 millimeters. So if I said to you, you have two presentations, one is 5 millimeters and the other is 1 millimeter, what am I trying to say? The rate is more or less? No. I'm trying to tell you that the amplitude is greater or less. Okay? So now when I try to count this out categorically, if I told you, hey, this is a 6-second strip, well, that'd be easy. 1, 2, 3, 4 times 10 and 60 seconds, that's a heart rate of 40. But we don't know that. There's no nomenclature here outside of the scale I put at the top. This is how you count it. We find a QRS complex, or an R wave, as this is, that falls on one of the big boxes. Each one of these is 0.4, 0.4, 0.8, 0.12, 16, and 20. And so a big box is 0.2 or 20. You don't necessarily need to know 0.04 and 0.2, but what you should know is that there's big boxes and little boxes. So we look for one where a QRS complex, do you know how there isn't a Q and there isn't an R? There's no Q wave here, there's no R wave here. Oh, sorry, S wave, forgive me. There's no Q wave, no S wave. This is a QRS complex that has no Q and has no S. It's a longer discussion. But either way, this is my QRS complex, or specifically my R wave. Do you see where this R wave falls directly on this big box? That's our 0 point. And every big box after that goes down the scale. If I had a R wave that was right here, what would my heart rate be? 300. If I had an R wave that fell on the second one, what would it be? And so this one falls between 75 and 60, which tells me even with just these two beats, I can guess with a reasonable determinants 300, 150, 175, and 60, so about, I don't know, 65, whatever. But the question is now, what should you suspect? Is this rhythm bradycardic or tachycardic? Or not? It's not, right? It's what we call a normal sinus rhythm. Falls within the normal rate. Not for nothing, but sinus rhythm, we heard this term. This is a sinus rhythm, this isn't. Sinus means it comes from which node? Sinoatrial node, which means it's normal. How would I know that this one is sinus in nature?
Because it's within this normal range. Right?
Maybe, but what if it was ventricular, but just sped up, right? How can I detect when the sinal node is depolarizing? What's this?
Oh, yeah, the atrial's.
I can see it.
Because it's there.
If the sinus node wasn't depolarizing, which is located in the atria, that would not be here.
And if you cover it, it's still there, right?
But it's not there in my heart, India.
No,
Alright.
it's in your hand.
So is your heart. Alright. So here's another strip, right? This one is particularly difficult to see. The lines are blurred out largely. I'll admit, it's actually really easy for me to see, but that's because I spent over a decade looking at them. But when I look at this, I'm like, oh, I bet that'd be pretty tricky. Can you kind of see how the large boxes are falling here a little bit? Right? And so what I want to do, how I count this out, is I just go over to the one that's lined up with the large box right here, and then I count every other box that falls between. So if I asked you, what is this rhythm, you know, what rhythms do you know this is not?
VFib.
It's not VFib, obviously. What else is it? Obviously not. It's not asystole. What else is it? Obviously not. VTAC. What else is it? Obviously not. VFib, sure, things like that. But here's what I found of cardiology is most people think I just have to look at this giant spanning nebulous form of cardiology and figure out exactly which one this is. No, here's cardiology in a nutshell. Are you ready? All of your rhythms will either be too slow, too fast, or bad. Now, what you already know, if we look at this, is if I say, oopsie,
It's like 56, 54.
if I count this out, there's my start, 3, and where you'll make this mistake is you'll accidentally count the first one as 300. That's what usually happens. Make sure you remember to start at 0, and the next box is a 300. We know this. How would you describe this rhythm? What's its name?
Bradycardia.
Right? Bradycardia. Because it's slow, yeah? Now, you know this is bradycardia, so what do you know it is not? It's not too fast, and it's not bad or irregular, like asystole or VFib or whatever the case is. So when I try to teach people cardiology, I say, no, start with 3. You know more of what this isn't than you know of what this is. It's not a trick question. Will a fast heart rate ever represent as a slow heart rate? Well, no, because then we call it a slow heart rate, right? So if you see tachycardia, you now know this is an asystole, VFib, You're like, oh, actually, I didn't know what this rhythm was, but I know a million things it isn't, which leaves only 1 or 2.
Also subordination.
Okay?
Can I ask a question
Certainly.
about the time?
Yes.
So the little boxes that make up the big box you counted as
0.04.
so how do we get like 50 increments? They're not
Because it's
how do we get the increments?
these, it's like saying how do we get 60 seconds in a week? You're like, how does that line up? I'm like, well, because these measurements are heart rates, and this is milliseconds. That is 300 beats a minute. This is 0.04 milliseconds.
Oh,
So that's beats a minute, not seconds.
thank you.
Yeah, good question. All right. What is the P wave? What does it do? What does it denote? Say it again. P wave is atrial depolarization. Do you mean to say contraction?
Yeah.
Not necessarily. Because the P wave is the visual representation of the electricity, right? What is the QRS complex, or the R waves? That is ventricular depolarization. Did you mean contraction? Not necessarily. How could I verify that this is not only ventricular depolarization, but also ventricular contraction? Pulse. It's both parts, right? It's not just if your patient's pulse, if your patient is getting enough oxygen, are they breathing okay? Depends. Depends on what. We know the chemical's all right. What about the mechanical? In fact, we do this as medics. I hook you up to my monitor and I run electricity through your heart and I see that all of a sudden. The next question is am I getting capture? Am I getting mechanical capture? I have to feel a pulse. That's not enough. All right. We can see this QRS complex. We can see the T wave. What's the T wave? Ventricular repolarization, right? It's a recharging to depolarize again. This area here, we've got the S wave and we've got the T wave. And this area in between is named the ST segment because it's between the S wave and the T wave. And you should know that this is our isoelectric line, right? Asystole mirrors or mimics or looks like our isoelectric line. It is a sign of zero detected electricity. Here's a trick question I hope I can remember to put on the test exactly. If you see a flat line, does that mean there is no electrical activity in the heart? I'm looking here at one of the leads, and the line is flat. Does that mean there is no electricity in the heart? And the answer would be, not necessarily. It just means there isn't electricity in the place you're looking. That's why we have 12 leads, not one. Because we have to look at the electricity flowing. I will say it's a little misleading. It's incredibly unlikely you're going to have asystole in a single lead. But the point is that asystole is a flat line because it's not detecting electrical activity, which means this is no electricity, that is no detected electricity, that is no detected electricity, right? It doesn't mean the electricity is not going there, it just means it's not going at the camera. Anyway, I'll say what I need you to know about STEMIs. Do we know what STEMI is?
Vaguely. Heart
Okay.
attack.
It's a heart attack. It is a ST elevated myocardial infarction. That's a STEMI. What that means is you're having a heart attack and I can see it.
Oh, that's nice.
Not all heart attacks are STEMIs. In fact, we call them NSTEMIs if they don't have ST elevation, which means a non-ST elevated myocardial infarction. What you should not say is, I don't see ST elevation, therefore this is not a heart attack. Careful. Now, realistically, it's not in our scope to say that either way, but I still think it's good for you to know. So what it might look like here, if I represent it in arrows, is if suddenly my rhythm looks a little like this, or maybe somewhat easier, if it looks like this. Is this notably different than the other one? And what that notable difference is that my S wave is no longer down here, it's just gone, and my T wave ends way up here. That ST segment is elevated, or an ST elevated myocardial infarction. Here's it without ST elevation. You see the difference? Here's it kind of overlaid, a regular one in green versus a one with an ST elevated segment. Of course, the S wave is here and the T wave is there. If we know that this, what line is this right here?
The
Isoelectric line. We counted a P wave at the start of that inflection off the isoelectric, and the P wave ends at the isoelectric line. The Q wave starts at the isoelectric, so if I said, where does the Q wave end and the R wave begin? At the isoelectric line. That's the end of the Q wave. And this is where the R wave starts. So then where's your S wave? Well, I don't have one in black. It does not go below the isoelectric line. Where does the S wave start in green? It starts at the isoelectric line, or the end of the R wave in this case. So these things are ending right here, and that means that my ST segment is the end of the S wave, the start of the T wave, essentially. In the absence of an S wave, we're just using the end of the Q wave, or R wave, as it were. Okay, most of what I said I don't know that you necessarily need to know. But what I'm trying to kind of show you is that represented in teal here is the ST segment of my green EKG, okay? And then that in elevation is now here. That's when I say, I think I see a STEMI, that's what I'm looking at, that right there. Here's my isoelectric line in yellow. What rhythm falls directly on the isoelectric line? Asystole. This space rate here matters. We talk about, it's not just the presence of an ST segment. We talked about how they all basically have ST segments. Specifically, it's the elevation. How many millimeters of elevation does this have? Use boxes if you don't know millimeters. How many boxes?
3.
Right? 1, 2, 3. Each box is a millimeter high. So this has 3 millimeters of elevation. Most protocols say you should think heart attack if you see 1. 1 millimeter of elevation and 2 leads that are next to each other, let's just say, contiguous is the word. If you see this, not just in 1, but in 2 right next to each other, it's not even technically next to each other, it means 2 off the same coronary artery, but if you see 1 millimeter of elevation and 2 contiguous leads, you should suspect a heart attack. We call this fireman's hat sometimes, because it kind of looks like a fireman's hat. This is the curvature of the T wave and the spike on the thing. It's the classic heart attack presentation. There's a million different ways this can present. This is the classic one. The only reason I even go through this is I had a student say, I was asked on the registry what ST elevation was indicative of. So even though I explained all of it, all I mostly need from you is if I said, what is bradycardia? And you said slow heart rate, and I said, what is ST elevation? You should say, heart attack. That's mostly what I need from you. Don't go too in depth here studying all these different things. I think isoelectric line is an important word. I think knowing about elevation is important, but I need you to be able to start Googling 12 leads and interpreting them. That's not what we're doing here, okay? Does anybody see anything wrong with this rhythm? This is a 12 lead with lead 2 displayed along the bottom. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Now, is this heartbeat the same as this heartbeat? No, because it's chronological. First heartbeat, second, third, fourth, fifth, and so on. Is this heartbeat the same as that one? Yes, this is chronological. So these heartbeats are all identical heartbeats. Why do they look different?
Because it's looking at different places.
It's a different camera angle of the same heartbeat in chronological order. Why is this one larger than this one? Say it again.
Looking at different places.
It is looking at a different position, and therefore it's almost like if I'm standing here and you whisper, I can hear you louder than Peyton can. You're whispering at the same volume, but I'm closer to you. The camera here, this lead, is much, much closer in line to this electrical depolarization. That's why it's larger in amplitude of the electricity. If anybody, what do you know about this? You see this, what is your suspicion about this patient's condition? Can you say any words? Do they have a pulse? Probably, but we don't know. We know that this is electrical, yeah? What else do you know about it? Do you know anything else about it? Or suspect anything else about it? Again, this isn't your job to know this, but I'm curious.
I mean, it reminds me of VTAC more than anything.
Yeah, because it's wide, it's ugly and the like, right? It's not, right? See how narrow this is? what VTAC is going to be something like this all the time. Okay. Can anybody point out the ST segment in this location, this teal one? Do you see how, even though I taught you R wave, this one is pointed down? How could it be? Because the lens it is looking at is the opposite of the one I taught you. But can you see how that's still just obviously a big pointy triangle? That's ventricular depolarization. And so what follows it is the T wave, and in between is ST elevated, an ST elevated segment. Is this the only place that we see that? What about here? What about all around here? Now this one is only like one box. This one is like 5 little boxes plus 2. This one's 7. This one's 2. But I'm starting to see it everywhere. What did I say about elevation when it looks like you have a heart attack all over your heart? How could it be that this guy, what is a heart attack? It's an occlusion of what? Coronary artery. How on earth could this guy have an occlusion of both his LAD, his circumflex, well, I guess that's that. He doesn't have an RCA, but he's got a, how could he have an occlusion of all the rest of this at the same time? How did he not wake up 2 weeks ago with an occlusion of a part of it, an occlusion of the next part, an occlusion of the next, and so on
One
and so forth?
occlusion blocks blood flow to the rest.
Good. There are 2 answers to this. See if you can come up with a second one. But the first one is I am immediately suspicious of a heart attack. What other condition do we know that affects the entire heart? Angina is, I could see how that might be misleading. Not necessarily, but you might say my chest is tight. That's a good answer. Pericarditis. There's a second answer there that's possible. If you have an occlusion that's so far up as to block all the rest, right? You'll note I didn't say anything about occlusions over here. So it's not everywhere. How is it, Trinity, that a guy could have an occlusion in his septal leads, in his lateral leads, in his rear part? How could he have an occlusion in all of these places, but not in his inferior?
Blocking the coronary goes to those ones.
It's blocking the left coronary artery, potentially, right? Okay, again, it's not your job to interpret these things. I need you to know that ST elevation is what? It is indicative of a heart attack. And when I say elevated, I mean it's elevated above what line? Isoelectric line. I need you to know isoelectric and ST electric. Good, good, good. How are you doing? That's a lot of words. You need a break? You okay? How's your brains? We'll give it a quick 3 minutes. Cool down, recharge. Song my son showed me. That's my jam now. I'll never do that to you again.
I don't believe it.
Oh, sorry, I wrote anything.
What?
I remember when I offered you M&Ms. You were like, "Aren't those mine?"
Oh, yeah.
Oh yeah, right. Don't go home, Tina, and learn how to interpret heart attacks. Don't do that.
What if I really want them?
Know the other stuff first is, I guess, the message. If you come in and you're very good at knowing when to, how to recognize end STEMIs because of De Winter T waves or some such, but you don't know the anatomy of the heart, you're going to lose it.
That's my goal.
Fair enough. Track record seems to imply that. However you want it
You have a female patient. 3 hours.
to. She's single. It's important to people assessment.
3 hours of really bad stabbing chest pain. Gets worse with movement, inhalation, all of that. Lung signs are clear. That's all about what you got. What do you need to do?
How old is she?
18.
Whoa, PD. Take birth control?
No.
Planes, trains, automobiles, big car rides?
No.
Sick recently, laying around a whole bunch?
Probably laying around a whole bunch.
Oh. Surgeries?
Nope.
IUD?
Nope.
Birth control?
Nope.
Smoker?
You already asked that. No.
Smoker?
For sure.
Smoker.
I tell my doctors no too.
How'd she vote?
18. Hasn't had an election yet.
Did you see my plan?
One of those liberals. Okay. Yeah, I mean, I'm gonna guess PE. A person that young, if it's not isolated anxiety causing hypoxemia because you're just overworking your own heart momentarily, I'm gonna guess some type of clot. Too young to have any major chronic conditions like heart, lungs, whatever. I'm guessing it's a fundamental mechanical issue. Unless, is she pale?
Yeah.
Yeah, it could be anemic, so she's prone to that kind of stuff. Heavy period lately, something like that.
Don't think so.
Okay. I imagine that's all women talk about.
Yeah.
Hey Susie, how's your period? Okay. Yeah, that's my guess. I go immediately with clot. I'd be asking things like COVID vaccinations. Has she had a cough lately? COVID came with a whole bunch of clot issues. Chest pain type. But it's probably stress. 9 out of 10 is stress. Not enough sleep. Too much caffeine. Alright. Talked about dysrhythmias. Talked about angina. We talked about how to differentiate angina from myocardial infarction, the suspicions therein. I want to talk about cardiac cycle. I don't know if we'll get to it, but I want to talk about the cardiac cycle, which includes things like cardiac output. It includes things like preload and afterload. Hear me when I say, if we don't have time to talk about it, I still expect a full understanding of it, which might require you looking into the slides or the book or emailing me. I don't know that we'll be able to get to it.
You'll get to what now?
Cardiac cycle, preload, afterload, that stuff.
Cool.
We talked about cardiac cell properties, excitability, conductivity, automaticity. We talked about tropic elements of the heart. If I give you chronotropic, organotropic, or dromotropic, what that might do. We talked a bit about cardiac monitoring. Does anybody know, what is itis implying?
Inflammation.
If I said endocarditis. Sure. If I said myocarditis. Now, I'll admit, I don't know a ton about these things outside of what you just said. That it's an inflammation of both some layer of the heart. How people usually get there is an outside infection that trickles down. I get a major sinus infection, it gets in my system, it goes through the blood, it lands on my valve, and now I have some type of, how does it describe? Endocarditis is described as, vegetation on the heart.
Gross.
Yeah, 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 it's a little broccoli.
Just turns into
It is,
something.
okay. How should you suspect endocarditis might present? Hopefully with a flamethrower. Kill it. Say it again. Spicy could be. Pain, if that's what you mean. Chest pain, right? How could you differentiate? Help me build a case. I think this guy has endocarditis, not a heart attack.
Recently sick.
Sure, very good. He's got an infection somewhere, right? Could be a fever, okay? Somebody not you. What I might expect if I said, I think this is stable angina, not myocarditis. Doesn't get better with rest is a great thing. Okay, this is what you're gonna need to do. You should list all these conditions. Sit down and say, what could possibly happen with the heart? Arrow, love, breakup, all these things. Myocarditis, angina, heart attack, all these kind of things. Ischemia, infarct, and say, what the hell is the difference between these things? I have yet to make that chart, but somebody needs to. Just a chart that just says, here's, because let's think about it. Your patient's in shock. What kind of shock is it? Well, we have to start asking other questions. Give me a reason, or sorry, a sign or a symptom, or a part of a story, or something that would make you immediately know it's one of the kind of shocks.
Bleeding out.
Bleeding out is
Hypovolemic.
hypovolemic shock. Very good. So if your patient has no indications that they are bleeding, your suspicion of hypovolemia goes down, right? Give me another indication of a shock that isn't hypovolemia. It's something that might make you think, wait a sec, I think I know what this one is. Anaphylaxis, right? Your patient has stridor. What's the likelihood your patient has stridor and cardiogenic shock? Come on, right? And so that's what we did with shock. Sure, they can mean tachycardia, hypovolemia, poor perfusion, all those things. That's not the parts I care about ultimately. What I care about is what makes them different so I can differentiate it, right? And the same thing is true now in cardiology. The same thing is true in respiratory. Patient has difficulty breathing. What could it be? Oh, geez, I don't know. Well, they're a smoker. Okay, well, I'm less thinking tension pneumo now and more thinking chronic condition. Oh, he had a nose bleed. Well, now I'm thinking it's physical obstruction. He's bleeding back into his, you see what I'm saying? And we need to be able to do that. Have you already made that chart? Is that what's going on?
Oh, no, you said no cardiac cycle and what else?
You need to know cardiac cycle, which includes things like cardiac output, heart rate times stroke volume, preload, afterload, that kind of stuff. But you know where you can find that all? Chapter 18.
I just couldn't remember. I was like, was it just the cardiac cycle?
It's a lot of crap.
Yeah. I was like,
Kind of, I think, the last place I want to talk about today is I want to talk about some assisted devices stuff. Sometimes we'll see a scar across the chest like this. It's colloquially called a zipper, right? If your patient is unresponsive and he's got a zipper here, you're suddenly greatly suspicious of a cardiac history, right? So you might see test questions or patients, real situations where your guy's unresponsive. It's obviously had some kind of endoscopy here. They went in through there, took out his ovaries or whatever. That's what my wife's looks like. But, well, I guess this could be female. Yeah, it's a girl. So maybe it was literally that. Yeah, it's hard to tell. All right, so this patient's unresponsive. What am I immediately suspicious of? Well, not pneumonia. Not really. Could it be pneumonia? Sure. But this chick had something wrong with her heart so bad they thought it worth risking cutting her open with a saw. Okay, that person has got a bad heart. Also, it doesn't look new, which makes me less suspicious of things like pulmonary embolism specifically. It's not a new surgery site. Maybe if it was, if it had a bandage on it, I'd be like, oh, even before, maybe she went in for a heart problem, came back with a chunk of something in her. Right? What I want to take a second to talk about is pacemakers. Right? We have some understanding of this. Can someone sum it up for me? My dad has to get a pacemaker. First and foremost, what is that? I like that. Yeah, something at least in your heart is not working, and we can have one of two types of pacemakers. If your heart is responsive to the SA depolarization or atrial, we may just have an atrial pacemaker. We might. But we can also have a ventricular pacemaker, in which case it goes down here, and that's where it starts to beat. Or you might have an AV pacemaker, where the wires go in here like we can see everywhere, in the atria and the left and the right ventricle, and it just shocks everywhere to get the heart to react. Does anybody have any idea how this looks on the monitor?
Not really.
Okay. Arrows? Very good. Yeah, well, so arrows is going to be, I think, some, like a life pack will interpret it. It'll say, like here I'll have what's this wave? The first one. P, very good. Now, regardless, let's see, what do I have ultimately right here? QRS, but I don't have an S here, right? Making this just my R, yeah. And then I have what? It's my T wave, very good. Now, something like a life pack might have something like this and just say, hey, I've detected a pacemaker spike here. How it visually looks is like, it looks like that.
Oh.
Like whimsical flowing lines, kind of straight and then suddenly like a straight, crazy line. Why? Because it's literally electricity. It's not sodium potassium changing place across the cellular wall. I shocked you. That's why it's a sudden spike of electricity. Now, is this an atrial or ventricular pacemaker that this guy's got? Atrial. In which case, if we saw not this, right, and we saw something like these, what should you suspect? A ventricular pacemaker. Apparently this atria didn't need to be paced, whereas it is like, hey, your ventricles aren't working very well. I'm going to give them a kick in the butt to remind them to beat every 10 seconds, I guess? 6 seconds? Every 6 seconds or something? So this is what a pacemaker looks like. And the next question is okay, so that's what a pacemaker is. Why do people get pacemakers? And people largely get pacemakers for one of two reasons. Either their heart rate is too slow, or it is irregular, which is akin to being too slow. Because even if I'm like, you know, beating a bunch and then there's this big gap and then two and then, okay, that's not necessarily slow. It's got the same amount as, say, this does. What would this be, by the way? Probably VTAC. See how organized it is? See how it falls on like the same mark each time? Whereas VFib might be like this. Okay. Anyway, I'm not trying to draw a VTAC, but the point I'm making here is you are going to get a pacemaker where it's like, okay, this right here, not okay. Can't have these big spaces, even though it's like beep, 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 okay? So a pacemaker will jump in here, cause a line. If it's atrial, it'll do this, and then ideally this. And it'll input those. That's what a pacemaker's for. Some are active, some are demand. Some are like, dude, I don't care what your heart's doing, I'm always sending electricity. Sometimes it's like, I'll wait till you start getting too low, I'll detect it, and then shock you myself. But that's what a pacemaker does. Any questions about a pacemaker? Sometimes they overact.
I think I missed something with the QRS, and you were saying that there's essentially no S.
Sometimes. It's like, give me a thumbs up left hand. Now give me a thumbs up right hand. Now I can see both of those. I can see your Q wave, I can see your S wave. Put your right hand behind your back with your thumb up. Can't see it anymore, but it's still there. Why? Well, because my angle is wrong. If I move the lead, well, there it is.
Okay.
So it's not that it necessarily doesn't exist, it's just that maybe your angle of looking is wrong, or not conducive to seeing it.
Thank you.
Yeah, man. So we can have pacemakers, we can also get AEDs implanted in our chest. Not called AEDs since they're implanted AEDs. But you might ask a patient, patients get these wrong all the time. They'll say, I don't have a pacemaker, I have a defibrillator. Or I have a defibrillator, I don't have a pacemaker. Well, okay. Whatever it is, it's in there. Something's in there. But we can also get not ICDs, but external devices. Here's what that might look like.
I've seen those.
This is an external defibrillator. Guy didn't need surgery, but we're a little concerned based on the monitoring of his heart. Heart monitors, sometimes people wear stuff like this. It's getting smaller and smaller all the time. But this could mean you walk up, this guy's unresponsive, you're like, this dude's got a heart history, holy moly, maybe this thing failed him and didn't shock him right. You probably got test questions coming, like you see a guy in a vest like this, the battery is low, it's not working, what should you do? And the answer is the same, you try to restart his heart, CPR and electricity. What's up?
So if you have a patient with one of these that's unresponsive, would you take it off so it doesn't like randomly fire while y'all are working?
So the question is if you have a patient that's unresponsive but is wearing this, would I take it off? And my answer would be, do they have a pulse?
If the pulse changes the answer?
It does. Because if he has a pulse, I'm leaving it. Because presumably it's working just fine. But if he doesn't have a pulse, this thing ain't working, it's gotta go. Good question though. Sometimes these things get low on batteries. Sometimes they sleep on them, they pull out the wire. This guy had dementia, who knows, right? Does anybody know what an LVAD is?
Oh yeah.
LVADs are wild. Left ventricular assisted device, LVAD. This is when you don't have a heartbeat. Your heart doesn't work, so I hook a pump up to it so you can live. These patients don't have pulses, but they are alive.
I've had one.
Yeah?
Yeah.
It was weird. Could you feel the turbulence? Did you feel anything? Sometimes they present with electrical depolarization. Sometimes they don't. Sometimes these patients appear as asystole on the monitor. Their heart doesn't have to work anymore. We're running the fluid for them in their own house.
It's kind of cool though.
Kind of wild.
So
So how would you know if this guy wasn't looking at you or talking to you that he was dead? If he never has a pulse?
Is he breathing?
Huh?
Is he breathing?
Let's say he is not breathing. Do you do CPR on all people not breathing? Not if their heart is working. And if this guy's machine's working but he's not breathing, if you do CPR on this, you might dislodge the pump and kill him. And all it was just apneic, not... Tony, what do you got, buddy?
Is he cold?
Okay, fair enough. Let's say it's hard to tell. You found him outside. Maybe his skin is cold, but it's cold outside. Sure, so he's definitely breathing, but his heart doesn't beat.
Get him to the hospital.
Okay, that's a good idea. Oh, you can do this.
Find out if he's got an extra battery on hand for that,
How
right?
people like either black heart people, so can you like check their little thing?
Battery.
Did I miss anything? We've got check the thing, black tag.
Like how can you tell?
Well, it's because it's like I always say,
Back
the
pocket.
number one sign that you've retained ROSC is a return of pulse.
Oh.
Responsive to some sort of stimulant?
Sometimes people come back from cardiac arrest, they just lay like fishes until we put them in the ground. End title.
Of course.
Right? Heartbeat or not, if my dude's cranking along with good respirations and a high quality end tidal, the dude's perfusing without a heartbeat somehow. Well, somehow is we put a machine in him.
So he's acting.
Which is why here's what the answer is to a question in most protocols. If you walk up and a patient it has an LVAD, is unresponsive, you don't start CPR, you pull out his card and you call the hospital he got it from and you ask them, do you want me to do CPR or not? I can't remember who is who, but like Emory will say yes and Kennestone will say no, depending on who put it in. Their policies change. To which I say, do what your protocol says. But what I did as a medic is, if you don't have a heartbeat and I don't start CPR, you are definitely dead. But if I do CPR and I dislodge this, that could be a problem, right? So it's awkward because now you have to pull the card up, call the place, and they say, our protocol is when your patient is unresponsive. I say, okay, well that took 6 minutes to get to you. Hopefully they don't need this CPR I'm about to do. The point is you gotta call the company or the people that put it in to see what their protocol and what they want to do. But my recommendation is you put on end tidal while you're making that decision. That will really help things. If his end tidal is high, he's perfusing. Don't do CPR. If they're like, I really think you should, you say, I don't know, dude, he's got a good perfusion. You still want me to do CPR on a guy that's somehow perfusing without a heartbeat or a heart blood flow? These ones can be tricky. I always love putting them on a 12 lead, checking their blood pressure and stuff. You get all kinds of wacky numbers and stuff sometimes. Sometimes you get normal numbers. That's the weirdest part. Okay. I kind of want to finish with a discussion about cardiac arrest. Poor Mr. Harris was blindsided by updated protocols there. This is about as simple an algorithm for your cardiac arrest thought processing as I can make. I say minute 0, though not technically minute 0, is when the AED starts to analyze, because it will analyze every 2 minutes. And every 4 minutes, you're to give what medication? So I kind of count the AED as minute 0, not technically. I do CPR for 6 minutes, so you give me the AED. Okay, we're getting far away from the point. But what will often happen is I find that even a bad answer is better than a good answer you never come to. I start doing CPR, I come in, we're going, oh, let's take Johnny to the hospital again, he's got a runny nose or whatever, and she's like, Peyton's like, all right, well, I'll get the PCR or whatever. And I come in, he's laying on the floor, his pulse is unresponsive, or whatever the case is, agonal respiration. So I'm like, holy crap, and I start doing CPR. She comes in, she's like, hey, Johnny, I'm like, she's like, what the hell? I'm like, I know, go get where it's cardiac arrest, go get the stuff. She's, all right. So she runs out, she comes back in, we apply the AED. As soon as it arrives, she throws the AED on and says, plug it and blah, blah, blah. Analyzing rhythm. I stop CPR, I am at minute 0. Because I now need to gauge my cycles. You're gonna forget the numbers you're on. Am I on the 3rd cycle, 4th cycle? I don't know. If you're using the AED, it will ping. When you go to be a medic, guess what I say? You pull up a phone and you have a timer set for 2 minutes. You need something to mark the points, I'm telling you. Guys always think it was nerdy. I'd put a metronome in my pocket and they'd be like, really, dude? Like, I do better CPR than you. Yes, really. Yeah, I don't feel good. I want to be cool. I don't want to be nerdy. But I'd rather save lives. So go, whoa. So there you go. I did it. Okay? So we put on the AED. It says no shock advised. I had already checked a pulse, right? I have to before putting on an AED. Yeah? As EMTs, I said, that's it. No more pulse checks. Why? Why do I say no pulse checks for BLS?
Because we can't do anything to bring it back.
You can. An AED can shock them. CPR would hopefully work, though usually it'd be the defibrillation and anything. But because there's only 2 things to improve the outcome of cardiac arrest, one of those is early defibrillation. What's the other? High quality, uninterrupted CPR. My guy does or doesn't have a pulse. It takes a minute. It's an advanced skill to determine a pulse in a guy that's got a blood pressure that's 0 over 0. Right? So I'm like, don't do it. They don't even teach it in BLS. Don't check a pulse after the initial one to make sure we're not going to shock pulsed V-tach into asystole. Okay. As AEMTs, I changed that to only assess for a pulse if end tidal goes up. If you're not taught how to interpret a rhythm, and this is the thing I know with the medics all the time, will VFib ever have a pulse? It's not a trick. Fair, because you might think some of those get big enough. The shortest answer I realize now is no. The VFib will never have a pulse. This will never move fluid in a way that you can feel it. That's what a pulse is. VFib will never have a pulse. Will asystole ever have a pulse? No, it will not unless it's equipment failure and not really asystole, right? So the medics, what they do all the time is they say, okay, let's do a rhythm check, it's asystole. Okay, and now a pulse check. What? Why? Go back to CPR, what are you doing? Well, we're supposed to check pulse check every 2 minutes. That's dumb. Now, Mr. Denner does teach that, because he's dumb. No, I'm just kidding. He teaches that because he has found that when you tell students to interpret when to check pulse or not, then they miss it, whereas if you just tell them to check it every 2 minutes, then they do it when they're supposed to. So that's why he'll teach that. But again, so then why am I not teaching AEMTs to check for a pulse? Because you're not trained to interpret the rhythms. So what I expect for you is hey, call 911 or alert the 911 system, go get my AED, initiate CPR. The AED arrives, Peyton comes in with the bag, and it's got the AED. My next step is AED, because it's, what do I say? 2 things that improve return of spontaneous circulation is IV and eye gels. Yeah. No. Because it's epi and IOs.
Yeah.
No. You are very ignorant. It's not. The point is that if I've got to prioritize things, I'm prioritizing the CPR because it works, I'm prioritizing the AED because it can work if they're in a dysrhythmia, it'll shock, but I am giving epi as soon as I can. I give enough epi to a hamburger, it's going to start talking to me. It is chemical electricity. Everything is electricity. How am I able to sit on this desk? Electricity. Because the electrons of these atoms are forcing against the electrons in my thigh, and it is keeping me from falling through this. Everything you touch is electricity, to a greater or lesser extent. Epi is chemical electricity, essentially. Yeah, that got me hyped, I don't know why. Yeah! Low chemical electricity! It works for some reason. Okay. Okay. So I want you to think that epi comes as soon as possible, but guess what I count as the moment, right? I'm using it off of the 2 minutes, right? I'm using the AED as a reference point. So what that means is let's say Peyton comes in and says, hey, I got the AED here with shock, not advised. Great, back to CPR. That's my minute 0. I give epi. Say, hey, pull me up some epi real quick. Great. 30 seconds goes by. 45 seconds. Admittedly, I didn't do a lot of hands-on stuff. I ended up doing a lot of CPR because people suck at it. But ideally, I step back and I'm just writing down times. Hey guys, we need that epi in 2 minutes. John, would you start pulling epi for me? Don't give it until I mention it. Got it. Okay. Hey, we're gonna switch out CPR here as soon as this AED says it's time. Okay? Alright. And I'm just writing stuff down. Just to keep it organized. You know? Anyway, patient comes up and says, hey, AED. Or sorry, CPR, let's trade out. Trades out, starts doing CPR. I start the IV, I give epi. Okay? Well, in 2 minutes, it's gonna say analyzing rhythm. I am okay with you just waiting for the next 2 minutes, that you give epi every AED prompt. I'm okay with that. It is, why? Because it will essentially be going every 4 minutes, which falls between 3 to 5 minutes. I'm okay with that. If an adjunct asks you, how often are you giving your epi, you should say either every 3 to 5 minutes, or every 3 minutes, or every 5, or every 4, every 4.1, whatever, but it needs to fall between 3 and 5 minutes, and you can do that because the AED will cycle every 2 minutes. So we want to give epi as soon as we can, or as soon as it arrives, but not at the cost of not doing the AED first. First, we want to apply the AED. We want to do CPR if it was immediately available, that AED. We give epi when we can, and now we're triggering every 5 cycles because the AED will prompt us every 2 minutes, and that's your cardiac arrest. Why is it devastatingly important that you apply end-tidal?
That way you can see them.
Because you can avoid checking pulses. You can avoid interrupting things. And if you see it go from 15 to 22, it's like, whoa. It might be, first you look at the guy who's bagging. Why do I look at the guy who's bagging? I just had a sudden spike of end-tidal. Why do I look at the guy who's bagging? Doesn't he have a pulse now?
Because that may not be bagging.
Because it might be going too slow.
The rate at which you.
Yeah, it happens all the time. They're like, hey man, would you blah, blah, blah. I'm like, yeah, Ross, give me a few squeezes there, bro. And he's like, shh. It's like, I'm like, oh, okay. F. But this is that. So we're gonna get questions on the test, talk about cardiac arrest, when to know this, when to know that. You might get LVAD questions. We might be running scenarios with that. Make sure you guys, so we're gonna be going to lab. We got another lab packet. Mr. Simmons wrote it for me, so God willing, I have an email waiting for me when I walk across the room, or else you may have a lot of space. These physical things matter on this, guys. Today we're gonna do the IO NREMT sheet. That means if Peyton and I are partners, Peyton looks at it, goes through it.